oral cavity, squamous cell carcinoma of the oral cavity is most likely to recur at the primary site. What they found out was the stage of the primary tumor was significantly correlated with the survival even after recurrence, but the stage of the recurrent tumor was not related with the survival. And the patients who were most likely to get benefit from the retreatment were those who had primary tumors of stage 1 and 2, those who recur greater than 6 months after their initial treatment, and the who developed recurrences that were amenable to salvage surgery. So, Agra et al. Basically in his study in 2002, they included 513 patients in which the recurrence rate in oral cavity squamous cell CA was 41%. And they also concluded that the patients with the recurrent oral and oropharyngeal squamous cell CA at initial stages and with a disease-free interval of greater than 1 year had a favorable prognosis. Then Lin et al. In 2004 included 190 patients in which 56 patients developed a recurrence. And what they found out was there was they defined an early recurrence, which was a localized tumor, which was less than 4 centimeter without bone involvement, and a late recurrence in which the tumor was more than 4 centimeter with a bone involvement. And they concluded that a 5-year survival rate for an early recurrent cancer tumor was around 60%, whereas it was 38% for oral for a late recurrence. Then Liao et al. In 2008 had done 272 salvage surgeries, in which they again concluded that the late relapse was associated with a better survival than that relapse which occurred actually within the first 10 months. And in early relapsed oral cavity squamous cell CA patients, salvage surgery was considered, in which the tumor depth of invasion was less than 1 centimeter. So it is a crux of all the studies which have been done in the literature in the past. And what they conclude is the overall success rate, the overall 5-year survival rate after a salvage surgery is around 40%. When we go by the history, so any non-surgical treatment, any non-surgical primary treatment is considered with a degree of a toxicity, which is determined by the type of treatment and an individual patient variation. So salvage surgery is not only done in cases with the residual disease or with the recurrent disease, and also for a toxicity related functional loss of the upper aerodigestive tract, like in patients with advanced laryngeal and hypopharyngeal squamous cell cancers who had gone a non-surgical treatment and now they are chronically aspirating, or maybe they have developed pneumonia or a cartilage necrosis. The mandatory point for a salvage surgery is recurrence. Whenever there is the patient has recurrence, it has to be resectable in terms of resectability criteria. We should be able to obtain the adequate margins, and the patient has also to be fit for an extensive surgery. So we know that 80% of recurrences happen in the first 2 years after the primary treatment, and there should be an ongoing follow-up in these patients. But any new onset pain, any new trismus, oral bleeding, oral bleeding or a weight loss or a persistent radiation edema should raise clinical suspicion, and all these patients should be thoroughly investigated. So the type of imaging has to be consistent with the pre-treatment imaging. Like for example, if we have examined with the CT or with the MRI, then that should be the dictum, that should be the imaging modality of choice in post treatment patients when we are suspecting a recurrence. When you are having a post-treatment edema and when there are post-treatment changes, then PET-CT whole body is the imaging modality of choice. There is a reporting template that's called a NIRADS system, which has been defined, which basically there are four categories, in which the category 1 is basically no evidence of recurrence is there and only post-treatment changes there. Maybe a scar is there, or radiation change, or a tissue distortion is there. What they recommend is a routine surveillance. Whereas in category 2, when there is a low suspicion of recurrence, like in PET-CT, there's a mild uptake, mild FDG uptake is there, or some lesion or some ill-defined abnormality is there, which is in the superficial surface, or it is deep. Then what they do is basically, what they recommend is basically direct inspection, basically direct clinical examination, and a short-term follow-up with a CT or maybe a PET CT. And category 3 is a high suspicion of recurrence whenever you have a discrete new or any enlarging lesion, or there's an intense FTG uptake is there, then definitely a biopsy should be done. Then category 4 is a known recurrence. So any surgeon who is planning for a salvage surgery should be mindful of the fact that about some of the tumor factors, like stage, that obviously early stage cancers are better salvageable as compared to the advanced stage tumors. 2-year DFS, disease free survival for a stage 1 and 2 is around 70%, and for stage 3 is around 33%, and for stage 4 is 25%. So Goodwin et al. In 2000 have mentioned about the site specific tumor factor also, and that is basically that laryngeal site has the best salvageable rate, and whereas the isolated neck has the worst survival rate. So the neck, if a single lymph node is involved and there is no extracapsular invasion, definitely the 5-year survival rate is equivalent to 60%. Whereas if you have a multiple lymph nodes and there is extracapsular invasion is there, involvement is there, then definitely that carries a poor prognosis. Then role of HPV, we already know that HPV positive oropharyngeal tumors are better salvageable as compared to the non-HPV positive oropharyngeal squamous cell cancers, because of the fact these HPV tumors are now being treated with a surgical modality initially, and we have a radiation or a chemotherapy which can be given in recurrent settings. Then the role of surgical margins is very important. We should be able to get the 1 centimeter clear margin, but sometimes because of the progressive fibrosis and because of the submucosal extent of the disease, they are not met with. So if we talk about the patient factors, patient performance status is very important. Every patient should be individually discussed in multidisciplinary tumor board meetings, and it should not be only decided by one particular surgeon or maybe by radiation or a medical oncologist. Long-term complications like a permanent gastrostomy, permanent NG, or a permanent tracheotomy have to be told to the patient. And comorbidities, particularly the diabetes or hypertension or any peripheral vascular diseases, should be actually noted in these patients. So the Kim et al. Has mentioned this index, which is actually used as a prognostic model in these patients with salvage settings. And psychosocial support is equally important, because every patient and caregivers have to be properly counseled, and they have to be told about the risks and the benefits. So now talking about the surgical principles, I initially discussed, and when I was discussing about the oral cavity approaches, so generally a single skin crease incision is advised, and the incision has to be given in along the RSTL lines, but except when the skin has to be resected. Exact approach has to be basically selected for the particular patient, and no trifurcation specifically unless mandated. And we have to respect the prior incisions. Like in the first picture, in the first image, there might be some modifications which we have to use in order to have a adequate result. And generally, the lip splitting is avoided. So here is a patient with the salvage surgery, and the mandibulotomy has been performed. And in another picture, basically this was a recurrence in the soft palate, which has been dealt with transoral robotic surgery. Then there was a patient with an extensive buccal mucosal involvement, right side buccal mucosal involvement with the retromolar trigone involvement, in which a very large ALT flap has been harvested, and basically it has been de-epithelialized in between to have a adequate cosmetic result. Then this patient had, in a salvage setting, had a very extensive resection, basically involving the maxillectomy, involving the segmental mandibulectomy, and basically the near total glossectomy. So here is a patient with a recurrence in the right side lateral border of the tongue, and with the isolated neck node. What we have done as a partial glossectomy with a neck dissection and basically a radial artery forearm flap. There is a patient with recurrence at the soft palate and the hard palate site, and basically it has been reconstructed with the help of an anterolateral thigh flap. So reconstruction after salvage surgery is very important. Use of pedicle and free flaps can be used. What is necessary is basically well vascularized tissue transfer has to be done in an irradiated environment, and generally local flaps are avoided. So sometimes the vessels in the neck in the salvage settings are depleted. So a pre-operative use of a CT or MR angiography is very important. Sometimes we have to, sometimes the ipsilateral vessels are depleted, and in those cases we have to use the contralateral site, and for those, the soft tissue and the bony flaps with an adequate pedicle length like that of a radial artery forearm flap or an anterolateral thigh flap, or maybe a fibular free flap are recommended. So sometimes the modifications have also been done, like in the cases where we want a bulk, then a radial artery forearm flap can be used, in which a proximal fat pad can be harvested and along with the brachioradialis muscle as well. And if we have an oral incompetence, then a vascularized palmaris tendon can also be used. So ALT flap also gives a good amount of bulk with a good pedicle length. And if we are thinking of a composite reconstruction along with bone, then a fibular free flap is an option. So when we have to reconstruct and we have to think of the vessel anastomosis, sometimes the vessels, I've already mentioned that the vessels can be depleted. So in those cases, the branches of the external carotid artery can be used, or the external carotid artery can be also used end to end. And transverse cervical vessels have a role when the level 4 neck dissection is not done, and it is this level 4 is not violated. And if we don't get any vessels, then the internal memory vessels can also be used, and the vein grafts. So when we talk about the complications in salvage surgery, the complication rate is very high, as it is around 67%. Like for the head and neck squamous cell CS, the Cleveland Endo classification is used, and there can be a progressive fibrosis in the flap, in the site per se, and the patients can have a permanent tracheotomy or a permanent feeding tube dependency. So to summarize, there are some negative or there are some positive prognosticators. Early stage disease, clear surgical margins, laryngeal site, HPV positivity, no previous chemotherapy, more than 6 months disease-free interval, or a single lymph node without extracapsular invasion has a good prognosis. Then an advanced stage disease 3 and 4, positive surgical margins, non-laryngeal site, HPV negativity, previous chemotherapy if it has been given, or a less than 6 months DFI, or if I have already mentioned that if your ECS is involved, or if there is more than lymph nodes are there. So the take home is basically the salvage surgery is the preferred rescue modality, but the careful selection of the patients have to be done. And when the patient is selected, thorough counseling of the patients and the realistic expectations have to be told to the patient and the caregivers. Thank you.
Thank you, ma'am. Any questions?
Jay, can I make a comment?
Yes, sir. Definitely, sir.
Yeah. Nice, crisp presentation, Raman. Good job. Couple of clarifications that I wanted to give with regard to the terminology that you used for Charlson Comorbidity Index and the Cleveland Endo classification. For the attendees, they are not specific to head and neck. There is virtually no specific head and neck prognostic index that is available that will help us predict the complications in head and neck surgery. Historically, multiple tools have been used, and I think you guys know because we discuss them very often. The revised cardiac risk index is a cardiac specific tool. There is the ACS-NSQIP, which we worked a little bit on for about 2 years, and after that, it was discontinued. Um, for all of you, ACS-NSQIP is the American College of Surgeons non-surgical quality improvement program. It helps you predict organ-specific complications. That being said, we probably need a tool that is specific to head and neck surgery, and I hope it will come from this part of the world where we do a lot of head and neck surgery and more so salvage head and neck surgery. Another point that she made, I'm glad that she referred to the Goodwin paper. The Goodwin paper has historically been used a lot to quote the outcomes from salvage surgery. And when you look at stage 1 to 4, non-stage specific survival was about 35 to 40%, which she already mentioned. So good job. And I'll wait for someone else to ask you some questions and comments before I make some general observations at the end.
Ma'am, I have a question. So when we are talking about salvage surgeries or salvage rescues, how important is the disease-free interval, ma'am? So whatever we have come across is, if the DFI is less than 1 year, then the outcome is very bad. So in those type of things, even if the disease which has recurred is very small, should we take into account, or should we consider anything else?
So, Dr. Ajay, I mentioned in some of the studies, the disease-free interval was taken as 6 months, and in some of the studies it was taken between 6 to 1 year. But generally, they say that if your disease-free interval is less than 6 months, then definitely you're going to have a poor prognosis. But at that point of time, various other factors also come into account, like the patients. Otherwise, if a patient is a young individual, if a patient has a performance status of 1, and the patient had or the patient had a tumor which was early stage initially and now also has a small recurrence, then obviously these patients should be counseled upfront for a salvage surgery.
Raman, can I add something to that?
Sure, sir.
So, Ajay, I think the most important determinant, especially in our country where head and neck surgery is still finding its feet in terms of structured training programs, is to review the prior histopathology report and to note the institution and the pedigree of the operation. Now, if the prior histopathology report shows closed margins or positive margins all around, you can pretty much assume that that would not be classified as a second primary or a recurrence. It would actually be residual disease. If the primary surgeon you think has already done whatever is possible, but still you have microscopic positive disease, in that case, that patient might not be a candidate for upfront definitive surgery immediately, regardless of the duration of the DFI. It is absolutely correct that when you have less than 1 year DFI, last Sunday we were discussing that in a very brilliant oncologist. I was in the panel and the same question was asked, what do you do with DFI more than 1 year, DFI less than 1 year? The ones which have DFI less than 1 year have to be critically analyzed for prior histopathology specimen report, a detailed evaluation of the surgery, preferably a personal conversation with the primary surgeon. Sometimes it's not possible, but at least a review of the notes. If the notes justify that the surgery that was done was all that could have been done at that time, you're pretty sure that the patient has more aggressive biology. There are some biological markers you can get done. In addition to what Raman said, I would consider that factor very, very seriously indeed to separate the residuals from the true recurrences. Does that make sense?
Yes, sir. Sir, again question, sir. Is there any role of this biological marker, sir, in cases of salvage setting? Because we know that the disease has recurred, and to better to address it, is there any biological marker, sir, which we can use it?
Raman, did you want to try answering that question? You've just reviewed this topic.
Yeah, so Dr. Rajay, a lot of studies are happening, a lot of studies on these cell checkpoint inhibitors are there. But these studies, first of all, if I talk about the like immunotherapy only, they have studied on the monoclonal antibodies. They have studied on the anti-CTLA4 basically, and a lot of these RAS pathways and PI3K pathways. But these studies are kind of like they have a very less numbers, and they concluded that like the use of immunotherapy they have done all these, and they were able to improve the survival maybe for next 2 months or maybe for next 3 months. So these are all preliminary studies. Not a defined that okay, this is the pathway, because there are multiple pathways which are involved in head and neck squamous cell CA.
So the pathways and the genetic alterations. One, the genetic alterations which have historically not been associated.
Your voice is a little less. I think.
So, Raman, I'll add to what you said. You're correct in mentioning that there are genetic alterations, but I would divide the genetic alterations into 3 kinds. One is the genetic alterations that are classically associated with causation of squamous cell cancer, like P53, like 9p loss. Those don't have any prognostic significance currently.
So your voice is very less. I think there's a mic issue with the device.
No. Are you guys being able to hear?
Yes, it's audible now.
Okay. So the first type of genetic alteration is genomic instability and other factors historically associated with head and neck cancer, which don't have any prognostic significance. Number 2 is the one that you were talking about, where people are using the pathways and checkpoint inhibitors to predict systemic responsiveness. To see whether or not, if you have a low DFI and a large recurrence and you're concerned about operating on that patient again, if you want to give any systemic therapy. The third and an equally important part, I think that was probably what Ajay's question was alluding to, was the importance of having markers which could probably push you towards surgery versus pushing you not towards surgery. Ajay, the answer to that is not clear. Ki67, MIB1 and other markers have been used. They are easily available now. You can get them done. The problem is that you cannot use that for decision making based on evidence. Like Raman said, these studies are small, single institute. What you can do is prognosticate the patient based on a positivity. Let's say someone has a Ki67 score of 60%. At that time, your prognostication will be much more somber compared to someone who has a Ki67 of 20%. So the only role that we have in markers of epithelial aggressiveness is biological aggressiveness, is that you will counsel that patient in a little somber way to be able to make sure that you are able to make them understand the outcomes. As she pointed out, overall survival for these patients is in the 30s. Median survival for a lot of these patients is 1 year. But the evidence is very clear, and this is a very important take home for all the attendees based on Raman's presentation, that when you have a recurrence, you want to give them as many modalities as possible, because that's the only thing that is associated with benefit, especially salvage surgery, which is why this question becomes so relevant. Salvage resections might be technically simple, but it's important that you bolster that with adjuvant therapy whenever patients are candidates for the same. I see one of our friends, senior otolaryngologist and head and neck surgeon, Dr. Rajiv Kapila, in the audience. I just think he joined recently. Welcome, Rajiv. If you can hear us, I'd like to know your comments as well. I think probably he's not there. Ajay, continue with your questions, and then we'll move on to Satyapal's talk. No?
Ma'am, the second question which I have is, most of the times whenever we are addressing this salvage surgeries or salvage settings, always the recurrence will be into a larger extent because of the neglect of the follow-up or anything. So how important is in these settings to address the contralateral neck or the lymphatic stations which are unaddressed at the initial surgery, because these patients would have already received adjuvant RT or adjuvant CT-RT.
Yes, so the protocols for a contralateral or the fundas for a contralateral neck will remain the same as for a primary tumor surgery when we had performed. I mean, there are no trials or no studies which say that if you have a ipsilateral recurrence and there is a big recurrence which has happened and you should go and operate the contralateral neck. But yes, definitely the tumors, when they are crossing the midline or you have a node which is equivocal on your imaging modality, and I mean, whatever you have used, CT or a PET CT has been done, and if you have a node which is on the opposite side and which looks equivocal, then definitely you should go and do the neck on the opposite side.
The thing which I have is how do we take into account these great vessels? Because most of the times during the initial setting only, if the disease is quite aggressive or anything, internal jugular vein which is commonly taken, and if there is a if in salvage settings, if the opposite side internal jugular vein is involved by the disease or anything, how do we address it? Is the reconstruction of the jugular venous system is mandatory?
So first of all, I mentioned that when I had a slide of a negative prognosticators and a positive prognosticators, I did not mention about the radiation. But 60 to 70% of the patients with a radiation who had already undergone a the radiation before salvage will have some intimal changes in the vessels, first of all. And at that, if you are planning a big recurrence resection and a reconstruction, you should be doing a pre-operative MRI angiography or a CT angiography to see the status of the vessels. Sometimes the patient has been operated outside and you don't know the status of the vessels. In those cases, the imaging is the preferred choice. After opening up of the patient, when you are before selecting any flap or before harvesting, you should be clear and you should be able to, we should see the status of the neck vessels. And suppose, like in your example, that if one side internal jugular has been taken, then definitely I mentioned that the contralateral neck has to be used, because it is very unlikely that both the internal jugulars would have been taken. So a flap with a good pedicle length has to be decided. And for the arteries, I told that yes, the internal carotid artery is a choice. But suppose if there is a lot of fibrosis which has happened in the neck and you're not able to isolate, then the transverse cervical vessels have a choice, do have a role. And if suppose the transverse cervical vessels also are not there, then the internal memory vessels can be used. And some of the people have also used a cephalic vein in the form of a correlate loop, in which they have from the deltopectoral groove, what they have done is they have clamped the vessel distally and they have rotated it and then used for the contralateral neck. And there was some mention of the ECMO also, in which a flap has been taken and oxygenated for about 2 to 3 weeks and then re-anastomosed. But it's a very initial kind of a thing, and the Wolf has done it, but no clear results are there.
Sir, one more question which I have is, if we are addressing very small primary diseases, for example, a buccal mucosal lesion, which was T1N0 to begin with, we have operated, and on to follow up again, they have developed a local recurrence, which is again T1 in nature. So, what is the role of adjuvant in these type of settings, sir? Again, multiple time recurrences, but the disease is localized and very small T1 diseases.
No, so can you repeat your question, please? I mean, so the multiple recurrences have happened and they have all been treated with the salvage surgery, right?
Yes, only salvage surgeries. The diseases are very small, which doesn't have any indications for adjuvant, apart from only recurrence being a factor.
Okay. So, but see, but if multiple recurrences have happened, and now this is the third recurrence or the fourth recurrence, and all the recurrences have been treated with the help of a salvage surgeries only. So the dictum is basically to again and operate. I mean, there is no role. I mean, there is no literature that if you have a particular 3 or 4 recurrences, then the re-radiation has to be given. I mean, sorry, not re-radiation or adjuvant therapy has to be given.
Any other questions from the audiences?
Hi, I'm Dr. Rajiv Kapila. So,
Good morning, sir.
Hi, good morning. So, just one question: that how often do you do genetic surveys of the patients post-op or recurrence? Do you do it in every primary cases or just in recurrence cases to prognosticate the patient?
I mean, sir, like for a routine, when we follow up the patients, we generally don't recommend a genetic screening because most of our patients have a financial constraints as well. So routinely, we don't recommend these patients for a routine genetic screening, and that's it, sir.
Okay. So any particular, at what particular time do you recommend that this should be done for academic purposes or for just your records seeking? I mean,
Sir,
you don't do in any of your patients?
Sir, actually, we don't recommend. I mean, in our we have an institutional philosophy, so we don't recommend genetic screening. But yes, definitely in the literature, a lot of thing has been explained. Like the Dr. Shamit sir has also explained about a Ki-67, then a cell checkpoint things are there, then the RAS pathway. All these things are there. But I mean, because of the financial constraints and because it's not going to change our treatment per se.
I can understand that.
Yes. So we don't have a philosophy of doing a genetic screening routinely in these patients, recurrent patients for a salvage setting.
So can I add something? Welcome, Dr. Rajiv. Relevant question.
I thank you, Dr. Shamit. Yeah, wonderful discussion is going on. So I was there.
You and your colleagues to join us. You have a large team yourself, so we'll request all of you to participate. I was on a con call in between, but if I believe Dr. Rajiv's question is to pick up those genetic instabilities in a recurrent cancer patient to help them prognosticate and then move on. Is that?
Yes, absolutely.
Yeah. So it's as much about the cost, Raman, as it is about the lack of applicability of the same in historically quoted literature. Dr. Rajiv, we've had studies on genomic instability, allelic instability, 9p loss, RAS mutations, as she mentioned, and EGFR. That being said, it has absolutely no prognostic significance. We know that 9p loss is associated with a higher risk of head and neck cancers. We know that there are going to be genetic alterations in recurrent head and neck cancer. That being said, currently, unfortunately, the data on that in head and neck cancers is not as elegant as it is, let's say, in breast cancer, where genetic instability can be used to predict how the patient's outcome is going to be. where nomograms can be defined to be able to tell us the survival with a particular genetic mutation compared to another genetic mutation. So unfortunately, the answer currently is not available with anyone in world literature, which is why
Right.
genetic testing is not recommended. But the only applicable criterion, as I was earlier mentioning, is systemic responsiveness. If a patient, and with the advent of immunotherapy, PD-1 has become a huge pathway in terms of helping us improve the survival of our patients. So if you have a recurrent patient who you think has very aggressive biological behavior, I would request you to consult your medical oncology colleagues to send a PD-1 test. So PD-1 inhibition associated with.
So your voice is very low, actually. It's not,
Okay, so bottom line is that you can consider PD-1 inhibition, and the other factors are not are mostly for academic interest. They have not really found extrapolation in clinical practice.
Okay, Dr. Amit, I got it. Yeah.
Sir, I would want to mention,
you.
like sir has mentioned about a PD and PDL1. So there was a like study which happened, that was a keynote 048, in which they compared the usage of a pembrolizumab with the versus pembrolizumab with chemotherapy. So they had defined a CPS score, which is a combined positive score. And if your CPS was more than or equal to 1, then they recommended a monotherapy. But in all the entire other population, when the CPS score, I mean the score of this PD and PDL1 was less than 1, then they recommended the pembrolizumab with cisplatin therapy.
Thank you, ma'am. Ma'am, shall we go ahead with the next presentation, ma'am?
Third,
If there are no more questions, we can go ahead. Dr. Satyapal, our fellow, will be presenting a case presentation.
Sir, should I start?
yes.
Yes.
Good morning, everybody. Today I'm presenting a case on Osteoradio necrosis. So these are the personal details regarding the patients. The patient's chief complaint was the patient have a discharge from the chin region since 3 to 4 months. The history of patient illness was the patient was having a discharge and pain in the lower chin region since 4 months, and also having a difficulty in the mouth opening. The patient taking medication from the local medical, but patient don't have any relief with that medication. The past surgical history was the patient underwent composite resection with the segmental mandibulectomy and a recon with the fibula-free flap in 2014. Then patient again have a second primary and underwent the right lateral tongue. Again, the patient have again second primary in the right lateral tongue and underwent wide local excision with the right modified radical neck dissection and the reconstruction with the radial forearm free flap in 2016. The past medical history was the only hypothyroidism, and patient also underwent the EBRT 60 gray in 30 fraction from 2026 8 2014 to 14 10 2014, and also underwent the IGRT 60 gray in 30 fraction from November 16 to December 2016. These are the general examination. The patient conscious, active, and the well oriented with the time, place, and person. The patient was well built. The vitals was normal, and the gait was normal. Pallor, icterus, and cyanosis was absent, and there is no clubbing and edema. On examination, on inspection, the left cheek and submental regions show the sinus tract with the discharge. There is a trismus, was grade 3, and exposed wound present in the lower anterior mandibular region, and no sign of any pathological fracture. There is a facial palsy which was grade 4, and the multiple root stem and the decayed teeth were present. On palpation, Face, the mandibular symphysis is tender and on palpation, and there is no lymphadenopathy. The provisional diagnosis by the osteoradio necrosis of the lower anterior alveolus. Now we are coming to the discussion. According to Marx, what is the osteoradio necrosis? The osteoradio necrosis is the cumulative tissue damage induced by the radiation rather than trauma or by the bacterial invasion of the bone. The complex metabolic and the tissue hemostatic deficiency seen in the osteoradio necrosis and seen hypocellularity, hypovascular, and the hypoxic tissue also. Now the classification of the osteoradio necrosis. According to Marx 1983, type 1 develops shortly after the radiation due to the synergistic effect of surgical trauma and radiation injury. Type 2 develops year after the radiation and follows the trauma, or the rarely occurs before 2 years or after treatment and commonly occurs after the 6th year due to the progressive endarteritis and the vascular effusion. Type 3 occurs spontaneously without a preceding a traumatic event, or usually occurs between 6 months and 3 years after the radiation due to the immediately cellular damage and the death due to the radiation treatment. Now, according to V. Joel and Epstein et al., stage 1, the resolved healed osteonecrosis. It is also further divided in type A and B. A, no pathological fracture, and B is the pathological fracture. Stage 2, the chronic persistent and the non-progressive osteoradio necrosis. Also divided in type A and B, no pathological fracture and the pathological fracture. And stage 3, the active progressive osteoradio necrosis. A, no pathological fracture, and B, pathological fracture. Now the sign and symptoms of the osteoradio necrosis. There may be a pain, swelling, trismus, halitosis, food infection in the area of the lesion, exposed bone, pathological fracture, and orocutaneous fistula. Now evaluation, plain radiograph of the mandible, the formation of sequestra or the involucra occur late or not at all in the irradiation bone because of the severely compromised blood supply. High risk of suspicion, that is the presentation may be recurrent or the persistent or even metastatic malignancy. Deep biopsy may be required. Review of the patient with the radiation therapy records, including the course of radiation therapy, the total dose per fraction, and the timing of therapy, and a thorough dental examination in those patients with the remaining dentition. Now coming to the management. Stage 1, perform the 30 HPO dives, 1 dives per day at the 2.4 atmosphere for 90 minutes in a multiplex chamber, or 2 atmospheric for 120 minutes in a monoplex chamber. For patient who respond favorably, continue treatment at a total 40 dives. For the patient who are not responding, advance to the stage 2. The stage 2 management, perform transoral sequestromy with the primary wound closure, followed by continue hyperbaric oxygen to a total of 40 dives. If wound dehiscence occur, advance patient to the stage 3. The stage 3 management, patient who present with the orocutaneous fistula, pathological fracture, resorption to the inferior border of the mandible, advance to the stage 3 management. Immediately after the initial 30 dives of HPO. And the perform transcutaneous mandibular resection, wound closure, and the mandibular fixation with the external fixation or the mandibular maxillary fixation, followed by an addition of the 10 post-operative HPO dives. Now coming to the treatment plan of our patient, we did the removal of sequestra with the necrosed bone, and also the segmental mandibulectomy and a reconstruction with the fibula-free flap. Thank you.
Good presentation, Dr. Satyapal. Any questions?
Dr. Satyapal, in how many patients, in Osteoradio necrosis, the concomitant malignancy is also found?
Ma'am, as such, there is no literature, but ma'am, whenever you have osteoarthritis, we need to take a deep biopsy of that site, ma'am.
Hanji, may I wait कर मेरी present? Hello.
Yes, ma'am. Yes, ma'am. So, ma'am, we need a deep biopsy of that region, ma'am.
No, so there are some studies in which they have mentioned about a concomitant malignancy, and when they resected a ORN, they did a mandibulectomy, and basically the malignancy was found. I mean, because the dictum is to treat these osteoradionecrosis patients in like the way we are resecting a primary tumor. So I mean, with the 1 centimeter margins, because in around 3 to 10% of the patients, the malignancy was found in these patients.
Okay, ma'am.
Ma'am, just to add on, older literature was quoting about roughly around 20 to 25%, but the newer literature which quotes is less than 4 to 5%. If I'm right.
Yes. So it's around, some of the studies have quoted around 3 to 4% rate. I mean, less than 10%.
So since this is meant to be a preparatory thing for Satyapal also, Satyapal, how do you explain the discrepancy of findings? Why was the older literature reporting more, and why is the new literature reporting less concomitant malignancy in ORN?
Sir, because of that, sir, on that time,
So because Dr. Satyapal, because we really get ORN nowadays, right? Because initially when the radiation techniques were used, and but now with the advent of a modern radiation techniques like IMRT, IGRT, and with the 3D conformal planning, the rates of ORN per se in mandible and maxilla have decreased to a great extent.
जी ma'am.
So I agree with that. The question, however, was slightly different. The reason that you're reporting less concomitant malignancy with osteoradionecrosis these days is because you have better detection tools. The problem that used to happen in the studies that Ajay quoted, 20-25% was that soft tissue delineation never used to be that good. So bony pathology used to be considered as the only problem. Soft tissue pathology, trabecular loss, other issues, because there are differences in radiology reporting in an ORN case as well as a cancer case. It's not just bone erosion, it's also the pattern of bone erosion. Normally, when you have ORN, you will typically not have superficial cortical loss. You will have medullary problems, and then we're talking about the stage 3 cases. But with the advent of better CTs, better MRs, you're able to also delineate soft tissue extent, which is what has enabled people to do deeper biopsies, pick up malignancy within a setting of osteoradionecrosis, and then resect it appropriately. Another comment I had about what Raman pointed out about resecting ORN like a malignancy, that is true, but for stage 3 disease. For stage 1 and stage 2 disease, you typically perform a sequestrectomy, and in that case, it's not physically possible for us to resect it like a cancer. Also, Satyapal, in your presentation, you mentioned dives. I think we've discussed this in the past. The only randomized controlled trial looking at hyperbaric oxygen for osteoradionecrosis, the ORN96 study group, clearly indicated that in overt or in manifest mandibular osteonecrosis, there is very limited evidence for hyperbaric oxygen. So yes, you could do it in high-risk patients where you're performing post-radiation therapy dental extractions before the time period indicated, and in patients where you start seeing some changes which might result in ORN. In that case, by all means, you can use hyperbaric oxygen, but don't use it for manifest stage 3 ORN. In a group of surgeons, it's important to mention that those patients will be best handled by surgery primarily.
Yes, sir. Great. Sir, stage 3 is also be prepared only with the surgery only.
Yeah. So, and that's fine. But
Dr. Shamit?
Yes.
Do you have hyperbaric oxygen chamber in your center or in Jalandhar? I mean,
yeah, you know, the problem is, Dr. Rajiv, I think Ludhiana also doesn't have it, Jalandhar doesn't have it. For a while, I'll tell you the problem. With osteonecrosis, like Raman pointed out, has become so rare because all of us are using IMRT or at least 3D conformal radiation. We are getting it in less than 1% of these patients. And when we get them, we get fluid florid manifest osteonecrosis, like I mentioned, that in which hyperbaric oxygen has no role. R&R in Delhi used to have a hyperbaric oxygen chamber, which I used for about 3 or 4 years of my initial practice. After that, they closed it down. There are some hyperbaric oxygen therapy chambers which are utilized for other indications. Currently, I'll be honest with you, for the last 5 or 6 years, we've not needed to refer a single patient of osteonecrosis for hyperbaric oxygen. The reason for that is, one, it has become rarer. Two, we don't use it in manifest ORN based on the results of the only randomized control trial.
Yeah, so I got it. I was just curious because in literature, this has, role in many other ENT problems also. So I was just curious if in Jalandhar it was, because we don't have such facility in Ludhiana. Right?
Yeah, I remember that that initially the indications for carbogen therapy eventually became hyperbaric oxygen therapy indications. But I think that I share the common belief that we don't have any centers nearby. PGI used to have one functioning. I think they've also shut down. R&R definitely has shut down, that I know for sure. In head and neck oncology indications, the reason why it's not such a big loss for us is because in head and neck oncology, the indications have decreased with every successive year.
Yeah, thank you, Dr. Amit.
We had published in head and neck in 2011. This was part of the work that I'd done in fellowship, predictive factors for severity in mandibular osteoradionecrosis. And what was important is that we did not look at occurrence of ORN, but we looked at severity of ORN based on the stages, like Satyapal was talking about. And what we found was secondary infection was a very important correlate, especially with actinomyces, and that's been reported in other literature also. And we also found that post-RT dental extractions had a bias, which we anyway expected. So for all of you, I think there are a fair bit of maxillofacial surgeons in our audiences every week. So it's important to put this patient on dental prophylaxis prior to radiation, any patient, and then of course follow them very assiduously. And we are lucky to have a multidisciplinary team where we can have these patients follow up with a dental professional every single time.
I have a question, Dr. Satyapal.
जी ma'am.
So are there any success rates which are quoted in the literature for the patients who have been treated with ORN followed by a free flap reconstruction? I mean, because we have seen a lot of our patients, what happens is there are some post-operative complications which are happening, and sometimes the flap doesn't.
Yes, ma'am. Yes, ma'am. Ma'am, free flap has a higher success rate than ma'am in ma'am stage 3 patient. And
No,
ma'am,
so I understand that the free flaps have obviously have a better success rate, but I mean, is there any are there any studies which have been quoted in the literature about the what is the percentage of the success rate?
The free flap have 10 to 14% higher success rate, ma'am.
Okay.
Yes, ma'am.
What study are you quoting, Satyapal? Do you remember the study?
Sir, I have written, sir, one, sir, forgotten name of that writer, sir, but read the literature, sir.
I mean, in overall, if a patient is having ORN, I mean, what is the overall success rate in these patients?
After the treatment, the success rate, ma'am. After the treatment, the success rate, ma'am.
Yes, yes, yes. So overall treatment of ORN patients, I mean, how much is the success?
It's around, ma'am, 50 to 60%, ma'am.
Okay.
So I would say that the success rate is very variable. I think he mentioned a progressive variant of ORN. Remember that the disease is like a florid cascade of inflammatory mediators and fibrosis and hypovascularity secondary to a prolonged period of inflammation. The problem is with progressive ORN, you can't really define a cure rate, Satyapal. You get another focus elsewhere. The sequestrectomy will typically not be enough in a lot of these patients. And Raman, the few patients that we have treated together, you would recollect the incidence of post-surgical complications in ORN are much higher than the post-surgical complications even in per-primum cancer or sometimes even recurrent cancer.
Yes.
I agree with you that this should be treated with as much urgency and caution as you treat any recurrent cancer, because you're dealing with an environment that is so hypoxic that you will need to get something in there to replace the defect.
Okay. And Dr. Satyapal, I have another question. I mean, how do you decide? I mean, suppose you have a patient who has undergone surgery of a big buccal mucosal cancer followed by adjuvant therapy. I mean, what all things you should consider? I mean, how early, if suppose a patient has a bone exposure, has a plate exposure, has some infection going on in the oral cavity, how early you should intervene? I mean, is there any protocol for that?
Ma'am, the patient have a high chance of osteoradio necrosis after the ma'am finishing of 10 fractions, ma'am. Then,
Okay.
ma'am, yeah, ma'am. So, ma'am, on that time, ma'am, only the conservative treatment has to be given only. No surgical intervention at the time of ma'am radiation. After the completion of radiation, ma'am, 3 to 6 weeks, ma'am, we can intervene with the only conservative management, ma'am.
Okay.
Then, ma'am, if there is any dental need of dental extraction, ma'am, we can do the dental extraction without any manipulating the bone and recon with the graft and the ma'am suturing or tight suturing over the
Okay.
ma'am dental
So you
socket
mean to
time,
say
ma'am.
atraumatic dental extractions
Yeah,
can be done after 6 weeks completion of radiation?
yes, ma'am.
Okay.
3 to 6 weeks, ma'am.
Yes. Okay.
Dr. Satyapal, one thing which I wanted to ask you, when you are resecting in these type of scenarios like osteoradio necrosis of mandible and all, where do you limit your resection? When do you say, okay, this much amount of bone I've resected, now this is sufficient? How do you, what all criteria do you base your decision on?
Sir, in stage 1 and 2, sir, if there is need of only sequestromy, I will remove the sir necrosed part till the healthy bone, where the bleeding will start, sir. In sir, there is a pathological fracture or the sir ORN reaching till the base or sir involving the both buccal and the lingual cortical, sir. So there is also need of sir segmental mandibulectomy, sir.
So, I think I would just add it to Dr. Ajay's question that is there any role of frozen section? I mean, if you have resected a bone and you just the margins have been taken and you just send the marrow of the bone and to see if the further necrosis is there.
Ma'am, not for the necrosis, ma'am, because ma'am we are dissecting till the healthy bone, ma'am.
Okay.
Yes,
Okay.
ma'am.
Dr. Satyapal, is there any other treatment managements in cases of stage 1 or anything wherein you want to avoid surgery? Is there any role of any other medications or any other therapies?
Sir, in stage 1 disease, sir, we can manage conservatively. We will use the sir uh, zinc oxide and sir eugenol also in sir stage 1 only, sir. And we can use sir local application of uh, GIT and sir local application of yes sir chlorhexidine mouthwashes, betadine mouthwashes in stage 1 to avoid the any further infection, sir.
Okay. Because what I recollect is there is a role of antioxidants like vitamin E, and there is also role of zoledronic acid into these type of scenarios.
Ajay, they've been studied in an RCT, and in an RCT, even for, and depends on what classification you're using. But to my recollection, pentoxifylline, vitamin E, other antioxidants typically did not have benefit. The only pharmacotherapy that was noted as having benefit was antibiotics when secondary infection had already occurred. But treating them conservatively sometimes, especially in stage 1 disease, is a primum non nocere philosophy. You first do no harm, make sure that your patient gets some conservative treatment in by the time you reach that window where you can definitively manage the osteoarthritis.
Thank you, sir. Any other questions from the audiences? Before winding it up, I would like to share everyone that this was the last session of the current module. Regarding the further modules, it will be posted into the academic groups, and even the YouTube links will also be shared.
Thank you, Ajay, for sharing this. I think it's important that Satyapal's current case was relevant because Raman talked about recurrent cancer and Satyapal talked about another aspect when we deal with a cancer, that cancer or recurrent disease is not the only evil that we face. A lot of times we get this situation, a difficult surgical situation like one. Good job, Satyapal. I think you handled the discussion well. With regard to our future plans, we remain committed to our Sunday 9:30 morning time. Thank you all of you for joining us over the first two modules. The next modules will be related to head and neck cancer, might be general topics, might be specific. We are working on that and we'll share that information. We've also started sharing this given the encouraging response, on our Facebook head and neck page of Patel Hospital. So feel free to go there. And of course, the YouTube channel links will be shared with you at the time of sharing the information regarding the next module. Thank you.
Thank you, sir.
Thank you, sir.
Thank you, sir. Thank you, everyone, and we'll catch you up in the next coming week.